Good evening, everyone. I'm Faizal Kottikollon, Chairman of KEF Holdings and Meitra Hospital. Thank you for joining us today. We are excited to be speaking about our vision for healthcare and a constant effort to make a difference in the industry. I have with me an extremely interesting panel, my colleagues, Dr. Ali Faizal, who is a leading cardiologist and director at Meitra Hospital, Dr. Dileep Raman, founder of Cloudphysician, a strategic technology partner with KEF Healthcare and Meitra Hospital. And last but not the least, Dr. R Balakrishnan, renowned heart and lung transplant surgeon, not just in India, across Asia. Before I start with the challenges and opportunities, I want to talk about why I ventured into healthcare. Our journey began in 2011, where we dreamt of transforming public education and healthcare. We studied the most pressing challenges across both sectors. Our successfully transforming public education through the Nadakavu model in Kerala. So we have worked with the government, and government has transformed now 151 schools in the state of Kerala with the first model. I realized healthcare also needed a holistic transformation. We need to look at why healthcare is constantly stressed and why patients were not receiving the best care and experience. So the journey started in 2011, where I met my friend and brother-in-law, Dr. Ali Faizal, who was working elsewhere at that time. And we realized that healthcare needs an overhaul in everything. If you look at the healthcare, patient is not in the center, is outside the whole ecosystem. And most of the care is more of reactive, not preventive care. I think you need to go to the next slide. So today, what we are talking about is what is the changes we are looking at it. We feel that instead of reactive care, we need to look at proactive care. We need to prevent and manage our health issues more than just getting the patient sick and trying to solve that issue. And that is what we are focusing in KEF Healthcare. And my colleagues, Dr. Ali and Dr. Dileep Raman and Dr. R Balakrishnan will be speaking on the traditional care delivery model, clinical bandwidth, what is the technology adoption. So you will get the holistic view what we think we needed in healthcare. And that is where we chose the topic, future-proofing of healthcare. Next slide. Next one. Today, if you look at the world hospital bed per 1,000 population, according to WHO standards, still in India, it's 0.5 per 1,000 ratio. UAE is at 1.4 per 1,000 ratio. And what is minimum required standard is 3. And the United States even is less than 3. And that is why we feel there's an immediate need for the development of hospital beds, especially in underserved countries. So we started our research in 2012. How do we solve that problem? How do we design hospital in a quicker manner? How do we execute the hospital in a quicker manner? Because normally from the concept to execution, in general, it takes 5 years. So what we have done was we decided to come up with the concept of, next slide, catalog hospitals. We started to work with various partners across the globe. And we said, how do we use the standards, whether it is JCI or other standards of different countries, and try to automate the design itself, and transfer this design to an automated factory. And we thought we will call this as manufacturing concept instead of constructing the hospitals. And we came up with all these different designs and showcased a model in our first project in Kerala in Calicut. So this is a catalog. You can pre-design everything. It has got all the specifications, all the bill of quantities. Every detail is in the catalog. And this is transferred to an automated factory, which we built in India near Bangalore. And that is where every component, whether it is the concrete, whether the wood, whether the steel, everything is manufactured, including the toilets, the ICU rooms, the headboards. And we bring it to the site above the ground and assemble it together. This is a hospital in Calicut. It's a 450,000 square foot hospital, built in 18 months in a single shift operations. The total number of employees was around 150 to 200 people maximum. It was a green construction. It was done in a very methodically, step by step. Every floor was built and completed before we go into the next floor. The concept was, how do we make the patient feel comfortable? So we came up with the concept of hospital. A hospital should not be having the smell. I mean, it should be a welcoming space. And that is where we combine the hospitality into healthcare. And that is why we call it a hospital, is a hospital. And you can see this the receiving lobby for the patients. And it's like a 5-star hotel. And this is not just for the people at the high-end category. It is affordable to everybody. We because of the time is reduced from 5 years to 18 months, we are able to give the same price component to like any other hospitals in our local markets. Next. These are a typical room. We have 220 single rooms like this. We don't have general wards. Next. So these are our suites. So this pandemic has proven that irrespective of countries' healthcare capacity, we still try to struggle to meet the demand, and that is where these technologies are important. We need to implement the infrastructure very quickly, and we have seen across the world, during the COVID time, we were running short of ICU beds, running short of capacity across the globe. And I think today, what we have done in India is a model which can be replicated across the globe. So we think that the hospital design and construction has to move away from the traditional methods what they're using now to more automated methods and automated factory environment, so that even the quality become much better compared to what you are seeing in today. Coming back into the preventive side, we said, how do we connect health and wellness together? So this is a project which is 25 minutes away from our hospital, which is an ongoing project which will be opened by end of next year. It's a huge vision. What we believe is, going forward, the hospital should be constrained only for the surgeries. We should move the care closer to the home of the patients. Dr. Ali will be speaking how we are doing this with technology, and all the rehab, all the wellness side should be in a separate environment. So this is a fully sustainable model, 30 acres of property, where we have our fully developed organic food. 70% of the food is grown here. We have the most sophisticated rehab facility. We have physical medicine experts located over here. We have a spoke from a hospital here. We have doctors, which is connected also to remotely to any specialist the patient wanted to speak to. It is a 100-key hotel. It's a wellness hotel, and the environment is such the patients will not feel claustrophobic like in hospital, and the healing becomes much faster. So we are moving towards preventive side, also getting cure faster. And here we also educate the wellness part, to the patients, also to the new client patients coming in over here. How do you treat yourself? How do you treat your body well? What kind of a nutritious food you need to consume? So this is what we are thinking is the future of medicine should be, and that's what we are working on in KEF Healthcare. So now I'll pass to Dr. Ali Faizal, who is the board of director of Meitra, and also the chief cardiologist of our hospital. Dr. Ali.
Good evening. Thank you, Mr. Faizal, Chairman, and thanks to Arab Health for giving us opportunity to talk to all of the people there and share our vision, what we have done and what we are planning to do in future. So the session in the talk, what I am be talking about is a traditional care delivery, what is happening now, and how it has been shown in the recent immediate past that this traditional care delivery may have to be changed, how healthcare is delivered to people all over the world. So, next slide.
Next slide.
Yeah. So, if you look at the traditional care, so normally it is a single hospital based, there's a large hospital. And if you ask us, we have built one of the best hospitals in the country now, which is Meitra. One of the best infrastructures, the best equipments, one of the best assembled medical team in the country now. And since the last 3 years, we would say that we are not done badly in the region. But then we also realized that just making one hospital like this, we will not be able to touch the healthcare of a larger section of the public or the people. So that started us thinking what to do next. So when you talk about hospital-based care, so you're talking about the primary care. All of you know in the healthcare that there's a primary, secondary care, and tertiary care, and also what is called as the emergent or emergency care and critical care. And these are the key deciding areas, especially the emergency and critical care, which basically decides the outcomes of patients. So when you look at this, there is a problem now. The problem is called as access to care, which is the biggest problem facing not only in India, UAE, or all over the world. Especially the pandemic has shown that access to care is a key issue. So how do we overcome this? This started thinking, and then we started thinking more and more. So even before the pandemic came in, we realized that the main hospitals are responsible for in the territory to give the critical care. And as I said earlier, this is responsible for the mortality outcomes, but this cannot reach the periphery and reach all the public and all the people here, even in the state of Kerala, where we are now located. So what we brainstormed was that the concept is to take secondary and advanced care to the patient, to the periphery, and guided and connected to the hub hospital, which is the main hospital, where we call, here it is called as a Meitra Hospital in Calicut. So next slide. Yeah. So next slide, one more slide. Yeah. So we decided to go first in Kerala, and one of the northern districts of Kerala is Kasaragod. So we decided to go forward and test this concept. So we decided to build a spoke unit, which has got the clinic there, and also a tie-up with the secondary hospitals to give advanced care. So if you see the slide here, you unfortunately I cannot move the mouse here. So there is a main hub, which is Meitra. So it is connected to the what is called as the spoke clinic, which has been made, and the spoke clinic is manned by a family physician. And this also, I'll go into the details of the spoke clinic. And in the same region, we also felt that just having a spoke clinic is not going to make any difference to the healthcare of the people. So to improve the secondary and tertiary care, we also tie up with like-minded hospitals and provide tertiary care facilities depending on what they need. And this is again connected to the hub hospital. Also, the emergency as well as the critical care also is connected to the hub in Calicut, which is Meitra. Next slide. So this is a hub where we operate. There is a command center, and this is connected to the periphery also. Next slide. So if you look at the spoke is one of the largest, at least 4,000, 5,000 square feet space, where there is family physician, other junior doctors, the nurses are posted there, there are clinics there, and all the people in this region, at least about 1.5 million people in the northern district of Kerala, is connected to the spoke. If they have a basic problem, they come to the spoke, they have consultation with the family physician there. 1 minute. And if these patients need any specialized care, they are connected to the hub through what is called as a device assisted. If you can show the device there, to the specialist at the main hospital in Calicut. So this device has got if you see, there is a monitoring of the pulse, BP, the ophthalmoscope, the spirometry, even the skin, fundoscope, everything can be transmitted live to the hub hospital. For example, a neurologist or a specialist cardiologist, skin and general physician, everybody can see the patient live on time and give advice to the family physician and the doctor sitting at spoke, and the necessary advice can be given to them. And if there is any problem, further problem or further treatment needed, they either is transferred to our secondary care center or tertiary care center at the periphery, and then if it is not managed there, we transfer them to the main hub in Calicut. So this hub, this spoke also has a advanced physiotherapy unit. Go back, please. Yeah, there is a pharmacy, there is a laboratory, basic tests, everything is done there. So when we decided on that, we also thought that if there is a spoke like this, if a patient with a chest pain or an acute emergency comes in, so there is a issue of distance. So that is how we came upon the idea of starting this asset-light model of starting. Next slide, please. Advanced care centers in the periphery. And this is one of the first center which is actually started in Kerala, where we tied up with one of the existing hospital in Kasaragod. And we have set up one of the very compact cardiac unit. If patient with a chest pain comes, they can be treated for a primary angioplasty, all elective emergency angioplasties. And we are also looking at even providing basic cardiac surgery care there. There is an advanced ICU there, which is connected through our tele facility to our team. And the emergency care also is there in this hospital. So the idea was to improve the care in these areas and save the lives of the patient. Next slide. So this is how this command center looks in from the hospital. This is in the main hospital. The one slide on the right is the ICU which we have set up in Kasaragod, where there's no advanced facilities. This is what we have set up there. Next slide. So go back one more slide, please. Yeah. So emergency and critical care is one area where we have found that in this peripheries there is a shortage of trained staff and personnel. So we are trying to improve the training of these people, bringing them here and then posting them in the peripheral hospital, improving the care. And the critical care unit is managed from the center, from the hub. So one of the advantages is that there is a major problem in the hub, they are immediately managed and then they are transferred here. One of the very rewarding thing what we recently, this has only been functional since the last 3 months. We are also looking at starting this kind of a tie-up with other hospitals across Kerala, in the state, outside the state, and internationally. We are also planning to start this kind of a tie-up even in Dubai, which we will soon be announcing. So next slide. So this is one rewarding case. Actually, this is, if you see that this patient was hospitalized in a spoke clinic in Kasaragod with severe aortic stenosis, a disease of the wall. Can you stop the video? Go back.
Go back.
Yeah. Just start it. Yeah. So this patient almost collapsed there. He was stabilized from there and was transferred to the hub. So one of the advanced treatment for aortic wall disease is called as TAVR. That is called as trans-aortic wall replacement. Most of you would have heard about that. So this patient was transferred in a mobile ICU in the middle of the night during the pandemic time when there was a lockdown. The government gave permission to transfer the patient, and the next day itself, patient after all evaluation went for the wall replacement through the what is called as a. You can play this video, please. So the team doing it here in one of the advanced cath labs in the hub at Meitra. This is a robotic cath lab. So we have what is called as a Dyna CT facility where the CT as well as the angiogram is fused together, and percutaneous valve. What you see here is a percutaneous valve which is mounted on a balloon. is introduced through the leg and then slowly advanced to the aortic valve and implanted there. Earlier days, this was done as an open surgery, and the main advantage is that the patient needn't be operated upon, and in a sick patient, this is much safer, and the patient can be extubated, the ventilators can be removed the same day, and within 2 or 3 days, the patient can go home. So these are the level of care. One, we are looking at the basic care at the spoke or the secondary level unit in the periphery, and if the patient needs advanced care, they have to be transferred to the hub, and then the proper care is given to them and send them back to the same unit where they're taken care by a doctor sitting at the spoke. So next slide. So one of the issues which we have faced now with the recent time is what is called as a sudden surge or deluge of patients, especially in the setting of the COVID pandemic. What all of us have come, suddenly patients come rushing to the hospital. There are no hospital beds, there are no ICU beds. So this started us thinking how to handle all this. So one of the thought process was that to reduce unwanted hospital admissions, and to do that we had to use technology. So this is one of the technology which we have been using. So if the patient is diagnosed to have an illness, either a COVID or any infective disease, they are sent back to their home. And with this kind of, can you play the device once more? So this is a home device which is kept under the bed of the patient. The patient's respiration, patient's saturation, patient's hemodynamics are monitored, and this is monitored at the hub center in Meitra by 24-hour coverage by nurses and doctors. And if there is any variation, major variation in the vitals of the patient, they are transferred to the main hospital. So one of the advantages is to reduce unwanted admissions so that the sicker patients can be treated. So we are also looking at the option of using wearables, because these are better technologies now available. So very soon we'll be coming up with it. And another thing what we are looking at is because of the surge capacity is to overcome the overcrowding of ICUs, to make the rooms ICU enabled or HTU enabled. And another problem what we are facing is the usage of equipments like ventilators and HFNC machines. So we are trying the option of pay-per use and rentals to reduce the redundancy of these equipments. So next slide. So if you look at it, if you want to go forward in providing healthcare, we have to move away from the traditional models of healthcare delivery, reduce inefficiency in hospitalization, move closer to the patient. That's what we are trying to do through local, regional, and international tie-ups, and also at the same time leverage technology to improve patient access to healthcare via tele or remote monitoring devices. So I will stop my talk here, and I'll request my colleague Dr. Dileep to take over the rest of the talk from here.
Thank you, Dr. Faizal. That's a great segue to what we are going to talk about next, which has to do with acting as force multipliers for the existing clinical bandwidth using technology. So I come from a space that is specifically dealing with the critical care problem in India. Next slide, please. The problem statement in critical care is of a staggering magnitude. We have more than 300,000 ICU beds in India that require critical care, which is a high intensity, high touch point model of care that is there in hospitals. But the gap in skill is pretty staggering. We have less than 5,000 trained ICU specialists, also known as intensivists, who are required to cater to this need. And this was a problem pre-COVID as well. And the COVID pandemic has acted as a stress test on this and exposed the shortcomings to a far greater degree than was commonly perceived. So there are challenges related to workforce and how they can scale. There are problems related to lack of training and skill, errors of commission and omission that can be committed because of these challenges. And the fact of the matter is that the patients are not receiving the quality of care that they need. To give you an example, only 1 out of 10 patients in an Indian ICU would be under the direct care of a trained intensivist. That is a fairly revealing statement that needs immediate addressal given what we have right now. Next slide. So the only technology that would go and address this gap in a short span of time is what is called as a Tele-Icu model of care, where you have one intensivist that is able to take care of 60 to 80 patients as opposed to the traditional model of 10 to 15 patients at bedside, augmenting the bedside providers, the bedside doctors and nurses with the critical care expertise from a centralized command center or a care hub that then connects to these spoke hospitals using technology platforms that allow critical care at scale. And we, working with Meitra, are doing this today in the entire region of North Kerala and hope to scale it further. And what this does is that healthcare suffers from a very, very well-known problem of the iron triangle of healthcare, where it is difficult to address cost, access, and quality all at the same time. And when you leverage state-of-the-art technology with well-trained intensivists and critical care nurses, that is one way to actually break this iron triangle of access, quality, and cost at a population level metric when you look at these problems at scale. Next slide. So the way that we are looking at this entire project working is the command center that you briefly saw in some of the images before is staffed by trained doctors and nurses 24/7. And we work alongside the bedside team. We engage with them, we help them with protocols, we train them, and then actually not only upskill them from a critical care standpoint, but also give them a layer of safety that their patients deserve that they did not have before. And what that does is it raises the entire foundation of the healthcare network in that area using Tele-Icu technology and support. Next slide. And what this eventually is going to translate to is better care, safer care, and patients that are more satisfied with what they are getting. The other interesting piece here that is very important is the amount of training and the amount of upskilling that we can provide to the bedside teams using this. So as you can see, we have these high definition PTZ cameras that can look at these patients with a fair bit of detail, with exquisite images that allow the remote doctor and the remote nurse to really precisely help in their care. All the devices that are at the bedside can also be connected and stream information directly into the hub, allowing the expert team to offer and deliver minute-to-minute care. All of this 360-degree evaluation of the patient helps the command center doctor and nurse assist in training and upskilling of the bedside, because as we all realize as clinical providers, technology is just a tool. It needs to be used efficiently to deliver care, but at the same time, fill the skill arbitrage with training and support that is much needed in our country and in resource poor settings today. So with that, I'll pass the baton to Dr. Bala, who can continue on some of the exciting work that's happening and also maybe touch upon the training angle a little bit more. Thank you.
You're muted, I think, Bala. You're on mute.
Okay. Thank you very much, Dr. Dileep. It's a pleasure to be on this program. As Dr. Dileep mentioned, the problem in especially critical care all over the world is not access, but lack of trained personnel. And historically, training of personnel has happened in medical schools or fellowships. But what happens to people who've graduated out of medical schools and fellowships, and then new technology arrives? Where do they have the chance to learn them? So this recent pandemic actually has opened up whole area of thoughts and ideas which we need to solve, because the crisis on the scale that we have seen is unimaginable. And every crisis in some way is an opportunity for change and for improvement. So I take an example of a technology which has been around for quite some time, but which really got its place under the sun and due attention, a technique called extracorporeal membrane oxygenation, which is nothing but but a sophisticated heart and lung machine where you can take the blood out of the body, put it through a pump and an artificial lung and put it back into the patient. So it's historically been used for both lung failure and heart failure. So we've been using it for three very common indications. One is resuscitation from cardiac arrest. As all of you know, when a patient's heart stops for whatever reason, uh, resuscitation programs exist where you we press the heart, intubate the patient, and try and resuscitate by treating the underlying cause. But the longer the heart remains asystolic or in fibrillation, the less likely is the patient to live. So we started a program where if after 10 minutes of conventional CPR following the guidelines of the American College of Cardiology, if the heart does not come back to a stable rhythm, we institute ECMO. Clearly, this means that you need trained manpower in the hospital 24/7, 365 days in a year, because cardiac arrest is such a time-sensitive event that if you delay too long, the patient's brain gets irreversibly damaged. So that was part of the training. We also use it in cardiogenic shock when someone has a massive heart attack, where despite putting in a stent or opening up the vessel, the cardiac contraction continues to be poor. So the only way these patients can live is by this kind of mechanical support. And now, in the face of this pandemic, what happens if your lung is so badly destroyed that despite ventilation, despite 100% oxygen, you're not able to have adequate oxygenation in the body? This is the only way of keeping these patients alive. Next slide, please. So we wanted to, first of all, make this technology more sophisticated, because what I found was a lot of hospitals have these machines, but they seldom use them because they've never used them. They don't have trained people to use them, and the less you use some technology, less likely you are to use it when the actual need arises. So it's a catch-22 situation. Just to highlight the possibilities, this is a young boy. He's an ambulatory ECMO. Historically, people think that if you're an ECMO, you have to be on a ventilation. We showed that you don't need to be. If your work is taken over by a machine, then you don't really need a ventilator. So we extubate these patients. Some of these patients are supported for up to 4 months. 4 months is a very long time to be on ECMO. So these patients are walking, they do exercise, they sit on a wheelchair and go out of the intensive care outside. So it's a dramatic change in the way intensive care is run. Historically, we used to keep them intubated, sedated, and paralyzed so that at the end of 3 weeks, their muscle power is zero and rehabilitation becomes difficult. So it's a radically different thought. Next slide. And can we play the video, please? I'm not able to play. Anyway, this is a patient who is on ECMO. He was on ECMO for 2 weeks. As you can see, I don't know the video is playing or not. He's actively exercising. We encourage them to sit on the bed. Next slide, please. Yeah. Okay. And it can also be used for cardiac failure. This young woman was airlifted from New Delhi with severe heart failure on low cardiac output. You can see the intra-aortic balloon pump. She's on a ventilator. She is an air ambulance. And once she reached our hospital, the next day she had a cardiac arrest. So she had a CPR for 35 minutes, and despite which the heart wouldn't revert back to sinus rhythm. So we put her on ECMO, and within 24 hours, she was fully awake, making urine. As you can see, she's been extubated and she's eating her breakfast. And 4 days later, we went in and put in an artificial heart pump, and she recovered completely. And 5 weeks later, she was back home in Delhi. So the only way these patients can be kept alive is by aggressive use of this technology. Next slide. And this is a patient who was in ECMO for 80 days, followed by bilateral lung transplant. And this is 2 months after a lung transplant. So this technology is life-saving. It's not very expensive. It's available in a lot of hospitals. But as I said, it's being underutilized because of the fact that not enough training has gone into imparting this to everyone. So next slide. this is another example. Most of you who are doctors in the audience would see this kind of patients every week. 70-year-old man, anteroseptal myocardial infarction, presented late, had an attempt at stenting. The ventricular function did not improve. He was on a ventilation for 3 weeks with an intra-aortic balloon pump. His creatinine was 4.2 with a blood pressure of 60 when he was shifted to us in an air ambulance. We put him on ECMO, followed by a ventricular assist device, and 2 weeks later, we transplanted him. And this is him after 1 month. Interestingly, at his age, he works as a freelance photographer for a National Geographic magazine and is a pretty famous photographer. So dramatic recovery from near-death situations is possible with this technology. Next slide. So the other thing, I'll come to the training part of it in the next slide. The other thing we found was how to teach people how. Go back to the previous slide.
Go back.
And can you play the video? So this is an implant of a left ventricular assist device. So what we found was one good way to teach people how to do it is by using virtual reality. So what we are now doing, and this might be actually applicable in catheter valve replacement, it might be applicable for aortic aneurysm surgery with stent grafts. So we get the preoperative CT scan or MRI of the patient, do a 3-dimensional reconstruction, and make a virtual heart and implant the pump virtually. So the picture that you see on the laptop does not do justice to the quality of the picture. So when you wear those 3D glasses, like a PlayStation glasses that your children wear, you get in glorious 3D color, spectacular images of the heart, so you can manipulate the pump, put it in exactly the right place you want so that the best possible outcomes are possible. And you can mark the spot on the heart where the pump should be put in. And this is called registration. So you choose the exact size by using 3D coordinates, so that if a young colleague or another surgeon in another part of the world needs help, we get these scans of these patients in the previous day, do this, and mark out the coordinates so that the implantation becomes foolproof or mistake-proof. So this is a work that we developed indigenously along with the Department of Mechanical Engineering and the Indian Institute of Technology. At this point in time, the time to reconstruct these images is around 6 hours. We are trying to automate it so that the time is reduced. But these are ways in which you can teach people how to do it. Next slide. Next slide, please. So what we then realized was we had to train people to be able to do so we currently run an ICU of 24 beds, patients on ECMO at any point in time. So clearly that means that historically ECMOs were done by cardiac surgeons. So one surgeon or 4 surgeons cannot possibly do so many cases. So we trained the intensivists in our hospital. We now have close to 25 intensivists in our hospital who are capable of initiating ECMO independently around the clock. And we have a very robust training program, and including for perfusionists, so that this can be taken up on a larger scale. And Ali, Faizal, and Dr. Dileep spoke about Tele-Icu. We are now linked with at least 6 hospitals, I think 7 hospitals, where we help run their ECMO program by using telemonitoring. So this the thrust of this meeting is how do we scale up and make it possible and democratize high intensive, high quality, technically difficult procedures so that the benefits reach to larger segments of society. And that's what we have done. We're also in the process of trying to develop low resistance oxygenators so that the domain of ECMO moves away from cardiac specialists or intensivists to general intensive care, where they can put these patients on ECMO without the need for specialists, so that more number of patients can be benefited. I give it back to Faizal to wind up the talk. Thank you very much.
Thank you, Dr. Bala. So as you all have seen, what we have done is, we created a sustainable model in healthcare. Yeah, I mean, if you look at it, we are gone from primary to secondary, how to connect secondary to tertiary and tertiary to quaternary care. And today, this cannot be with us alone. Today, what you've seen in this pandemic world, what we are living in, we need to collaborate together with other hospitals, doctors, because technology is there. The most powerful thing which we have done is integrating the technology with the patient in the middle. And that's what you have seen, starting with the construction technology, with the clinical expertise, with the clinical outcomes, and also giving accessibility of care to the patients, to their homes. And today, as you see, healthcare is in really a changing phase now. More and more patients will prefer to stay at home and get the treatment. And that's what Dr. Ali and Dhruv and Dr. Bala demonstrated, how we can integrate the technology and make an efficient system which is cost effective. If you really look at it globally, the biggest challenge for every government is the rising healthcare costs. That's because nobody is gone into the detail of integrating from A to Z. And that's what we have done it in the last 10 years of work. We started the work in 2011. It's not something which has happened overnight. Before we built the hospital in 2017, we knew this is the way model which we wanted to really demonstrate. Now what we are doing now is we are setting up the base in Dubai. This is for the Middle East patients with Canadian Specialty Hospital. We'll be setting up our first heart and vascular and orthopedic center here. Again, with the latest technology, what we have already implemented, and developing the entire hub and spoke model, not only in the Middle East, also in the North Africa. So we will have 2 hubs to cater to this region using technology and the expert physicians from all over the world. We are connecting the physicians, not just in India, from UK to US, and all through our network. And we will divert the doctors to whichever hub or spoke needed if patients wanted to meet them on physically. So I'm happy to take questions. I could see many of the questions coming on the cost. If you really see the construction cost, just to give you an example, today to build a hospital in US, it costs $10,000 a square meter. A same hospital in Middle East today, it's between the range of $3,500 to $4,000 a square meter. But what you have done to the global standards is $980. So if you really see, is 1/10 of the cost what in US, and 1/3 of the cost what is prevailing in the Middle East market. And the standards are in the top quality, because our hospital life is 100 years, because every element is produced with robots. So and that is where we bring down the cost on the infrastructure. If we have the good clinical care pathways, you can standardize the care, you can train more doctors, we can stay away from the star doctors, because today we need more doctors to see more patients, correct? And like Dr. Dhruv said, today on the bedside, we can maximum treat 10 to 15 ICU patients. But if you go to the remote ICU, you can see 70 to 80 patients. So I think this is a way we think that the care to be given. And future, if you have any more questions, we'll be happy to answer. So Sarah Faisal is asked, tech-driven healthcare and sustainable healthcare, how do they go hand in hand? Sure. I mean, so because technology is only an enabler, and it's all has to start from our basic value system. I mean, as you really see, I mean, the compassionate care is what every medical student will learn while studying the MBBS or a nursing even. So that is missing now in the ecosystem. And first, we need to bring in that compassion into the patient side and apply technology, to make this more accessible to the larger population in the world. And that is why we say it has to combine together. So I think Dr. Ali can take this. Have you defined the care cycle in your process of care?
The care cycle, when we started this concept of Meitra itself, we were very clear that how a patient has to go through the hospital and we call it what is called as care pathway dependent medical care in the hospital. So one of the ideas that any doctor who comes into the system should be able to give quality care with the best outcomes. So it is not individual dependent. So that kind of a care pathway has been developed, and we are in the process of implementing it. So a patient with a chest pain comes to the emergency unit, or a patient with breathing difficulty comes. So what we do is, based on the care pathway which is already built into our systems, the patients are guided by the physicians. So there is no individualization of based on the doctor's preferences. So some standards are set in, and this standard has to be followed, so that then only they can go to the next step of care. Until the patient is discharged, this is how we have been trying to develop the care cycle process in the hospital.
The next question is criteria in partnering with the periphery hospitals. What we normally do is we have a separate set of people to manage this. So we go to that periphery hospital and do a gap analysis. What do they really need? Is it the critical care? If it's critical care requirement, we go and install our technology, use Tele-Icu, connect it to a command center. So we solve that. In the case of Kasaragod, the requirement was there was no heart center in Kasaragod. So every patient with a heart attack has to rush in an ambulance to either Mangalore or a Kannur. So we decided to set up a heart center in 2.5 months. So today, most of the patients remain in Kasaragod. They need to rush in an ambulance to the other cities. So depending on the requirement of district to districts, today we are in the process of doing 4 more spokes in northern Kerala. We are looking at putting up a spoke in Bangladesh and Africa once our command center is ready in Dubai, so that patients can choose from these countries depending on their convenience. Either they can come to Dubai or they can come to Calicut in Kerala. So depending on the requirements, we set the parameters. So have we considered the possibility of remote surgery? Yes. This is other important aspects which we are studying now. We are talking and developing the technology for that. For example, now we are introducing the first robot for the knee replacement in our main hub. We are also starting the same thing in Dubai. And we are going to, through our command center, we can really see in any theater in the world and give a command to the doctor in Africa or in other parts of the world to do the remote surgery. So this is the immediate future we are looking at. So I think there's surely much better network. Yes, definitely. I think the Middle East needs the new model of care, because it's very, very fragmented. And that's what we are hoping now, by end of the year, we can develop this ecosystem and showcase it more. Cloudphysician technology, we are bringing in by end of the year. We are setting up in our first base hospital in Canadian specialty. And from here, we'll be expanding to whoever needs this service. So thank you again. I think that's it. Thank you, Ali. Thank you, Bala. Thank you, Dr. Dileep.
Mohammed.
Last question.
Ecmo was done. This is Bala's question.
Okay, this is an important question. Both on the basis of our own, we have now done, I think, close to 111 patients on ECMO. There have been also several large studies. The largest was published in Lancet from La Pitié Hospital in Paris. Roughly around 40% of these patients get weaned off ECMO. We have done, I think, 16 or 18 lung transplants. So if you include that, significant number of these patients who would otherwise have almost certainly died. I agree that almost 35% of these patients still die. That's because of a lot of other fact, because with the current technology, we are unable to maintain ECMO beyond 90 days. They get into other complications. So some of the challenges have been how to deal with anticoagulation, how to mobilize these patients, and how do you. ECMO is only a support technology. It does not treat the underlying lung issue. For heart, at least, there are VADs available or transplant. The number of donor organs for lung is a problem, especially now when we are inundated with the number of patients requiring lung transplant. There's been one report from Japan of using a living donor, but that's not been easy for us to start because of the overall incidence of this viral pneumonia. And so we've been very interested. In fact, I've been working with also Mr. Faizal's foundation. We really are hoping that we will be able to bring out a long-term respiratory support system like an LVAD for the lung, so that you could have somebody with an ECMO system running for a year, which is portable and worn on a belt along with a small portable oxygen concentrator, so that in our lifetime, I think it'll be a reality to see long-term patients requiring ventilator support on a device like an ECMO, like what you see for LVADs.
Okay.
Any more questions? So I think that's it. Feel free to wrap up. So thank you, Arab Health, for giving us this opportunity. We enjoyed the session, and I hope our audience enjoyed it too. And anyone wants to contact us, be free to get the details from Arab Health organizers. We are based in Dubai. We are at the DIFC. And soon I think, Bala, you have one more question.
Okay. Yeah, this is an important question. That was the fundamental theme of this presentation, is how do you make it possible to all the hospitals and patients to access the technology that's constantly evolving. There are three phases to this. One is, of course, the availability of the technology in that region. Number two is the cost. Number three is the expertise. Each of them needs to be addressed. Each of them is a different problem. One Faisal mentioned is just building hospitals, because not every hospital is modern. Not every hospital can have all the technology that you need. So you need a hub and spoke system where participating hospitals, if they're confronted with a problem for which they don't have a solution, are then able to contact the hub for seeking solutions, either in terms of technical help or by transferring patients. The second is, of course, acquiring the technical machines or whatever. And that is, of course, not possible in every hospital, nor should it be. For instance, you don't need ECMO in every hospital in a city. Even in a place like Dubai, perhaps you need 2 centers for your population, which are experts. So because transporting patients to them is not difficult. The third is expertise in running it. So if you have a very busy program, for instance, doing 150 or 200 ECMOs in a year, not only the team becomes very, very good at it, you can fly out to other regions, put patients on this and ship them back. You can also be involved in constructive research and trying to develop newer ideas. So one of the ways to make it democratically possible for everyone else is to impart training. And for that, you need sophisticated models of training programs. And we have a few in the pipeline, perhaps at some opportune moment. Mr. Faisal will share with you as to how we intend to go about that.
So thank you, audience, for the patient listening. Thank you, team. Look forward to work together and make a big difference in the healthcare transformation. Thank you again.
Thank you.
Thank you.